we would like to segue to our next speaker. I think this is Brian Skotko and Albert Pless. So I have an introduction for Brian. So he is a board-certified medical geneticist, has dedicated his professional energies towards children with cognitive and developmental disabilities, and he's a writer. In 2001, he co-authored the national award-winning book, Common Threads, Celebrating Life with Down Syndrome, and most recently, Fasten Your Seatbelt, a crash course on Down syndrome for brothers and sisters. Dr. Skotko is the Emma Campbell Endowed Chair on Down Syndrome at the Massachusetts General Hospital. He's also the director of the Down Syndrome Program and associate professor, Harvard Medical School. Dr. Skotko has a sister with Down syndrome. And Dr. Skotko will discuss improving healthcare access for Black and Spanish-speaking people with Down syndrome.
Thank you so much, John. Such a pleasure to be here. And I will be co-presenting with my colleague, Albert Pless, who's joining me. And Albert, I'll let everyone learn a word or two if you want to give an introduction about yourself.
Thanks, Brian. I served on this grant as the diversity outreach specialist. In my day hat, I work in diversity, equity, inclusion for a local town in Massachusetts, and I've committed pretty much 20 years of my public career in public health. So thank you for that, Brian.
So grateful to have Albert on our team for this project. We're excited to present all this to you. These are my disclosures that are also posted in the course materials. So when Albert and I started this work more than 2 years ago, we realized when it came to Down syndrome or people with Down syndrome, there was very little research on what were the clinical needs of people with Down syndrome who came from underrepresented minorities. The overwhelming majority of people with Down syndrome do not have access to specialty clinics. And we also believe going into that disparity might be exacerbated by those who have underrepresented minority backgrounds. And previous studies have also suggested that within our community, it's been difficult to recruit primarily Spanish-speaking and/or Black African-American caregivers, despite outreach. And the interest was to understand why. What were those social, structural, and personal barriers? And what were the facilitators that we might be able to overcome that? That allowed us to generate these goals. And Albert, I'll toss to you to review our goals.
Yeah, again, and we were excited about this project. And so, one of our goals was to better understand what these barriers and facilitators were for Black African-American, Spanish-speaking populations, trying to access their healthcare for their loved ones. And I think a big one for us, we wanted to create some tangible solutions to confront these barriers, because we realized, again, a lot of organizations and individuals were looking for things that they can actually have to work within. So these tangible solutions were things we really look forward to building through this project.
It takes a team, as many of you know. This is our internal team at Massachusetts General Hospital in Boston, which consisted of laboratory scientists, survey methodologists, research assistants, and clinicians. But we also wanted to make sure we did this with critical inputs from primary care physicians from around the country who are taking care of individuals with Down syndrome, also caregivers who have loved ones with Down syndrome, who also identify as being either primarily Spanish speaking at home and/or identifying as being Black or African American. And then we also wanted to work with our stakeholders, our community partners, specifically our community partners at the LuMind IDSC Down Syndrome Foundation, one of the national Down syndrome nonprofit organizations, and also our local Massachusetts Down Syndrome Congress, to understand at an organizational level how we could ultimately implement some of the recommendations that came from this. In our presentation today, we want to share with you our journey. And our journey together involved 3 elements. 1, gather information. While we had some ideas and hypotheses going in, we wanted to make sure we heard from stakeholders and got authentic data so that the data would help us drive our recommendations. Next, we want to share with you and report that data. What did we learn? And then finally, we want to say, it's not just enough to report, but how do we share? How do we change? How do we implement change? And we had a recommendation that came out of the group that we're starting to implement, which we will share with you at the end. So we're going to start with the gathering of information. What sort of data did we gather and how did we do it? And I know, Albert, you were really busy over these past 2 years.
Yeah, Brian, I think the key word you said was journey, because I think we really, and we've been on this together, and I think we did this in a few different ways, gathering this data. One is we're very intentional about connecting with primary care physicians, and we did these phone interviews with them, which I conducted the majority of those. We're really excited to hear, what physicians thought. Also, we really did caregiver focus groups, and I think we really, were intentional about making sure that we heard from caregivers and what they experienced in those. And then we also completed online surveys, which was the bulk of our data received with 109 caregivers and parents from them. And I think, again, we were very intentional because we wanted to capture this data in different ways, and, qualitative and quantitative. And so we were excited about the way we went about collecting this data.
And Albert, I know when you got the data, it then wasn't enough. You did a deep dive in coding, which took a lot of time.
Yeah, just very rigorous. Again, we just didn't want to collect it. We wanted to make sure we analyzed it, correctly. And so we, we used a qualitative analysis through Deduce, and we coded, transcript every single focus group, every single interview we did, auto-prescribed. We did everything through Zoom, as most things were conducted during that time period. But again, we really were intentional about really making sure this was a rigorous process in terms of looking at this data.
We also, as Albert mentioned, also did an online survey. So it's really great to go deep dive in focus groups with a few amount of people to get a lot of depth. But at the same time, we wanted to give the opportunity to families around the country who wanted to contribute their voices to our initial gathering of this pilot phase. As everyone knows, the work never ends, and this is just the start of many future research endeavors into this topic within the Down syndrome community. But we did design an online survey with input from caregivers. What questions do we need to ask in order to best get the answers that will lead to both structural and system change? Our survey was reviewed by the ethics board at our hospital, and we were proud to be able to partner with many of the national Down syndrome organizations and local Down syndrome organizations. And the survey was available from July of 2021 until October of 2021. We were happy we got 109 responses during the pandemic from families who were very busy taking care of their families, but who felt strongly enough to respond. You could see this is where they scattered. And for a pilot study, we were quite pleased that they weren't all just from Massachusetts. We had nice representation from many, although not all states, from around the country. This is just a nice slide that puts it together. How do we gather the results? As Albert mentioned, we had 3 sources of inputs: the caregiver working group, the expert advisory group, and the primary care working group. They were all the people who educated us at Mass General Hospital to be able to conduct the focus groups, the questionnaire, and the primary care provider interviews, which gave us that data. So it was a team element. And now, in the next part of our talk, we want to share with you the results of what we learned. And in the third part of the talk, we want to share with you of what we're trying to do in order to address some of those barriers. And in this section of the talk for our results, Albert and I have divided into what are the lessons that we learned from primary care physicians who are out there on the ground practicing, what are the lessons that we learned from caregivers who identify as being Black, and caregivers who are primarily Spanish speaking. You'll find that some of the recommendations overlap and some are distinctive, but we're going to present them to you in those orders. So first section, this is all of the research that comes from parents who identify as being Black, African American, of African descent, of mixed race. And these are our households who should be primarily English speaking. And Albert, I'll let you start. These are some of the rich quotes that you got from your focus groups.
Yeah, Brian, again, and as you know, and I think telling the audience today, we could speak about this for hours and hours because there's so much rich data we have. So we're gonna try to buzz through some of these slides. But this first quote, really from a primary care physician was really talking about the access to the medical system. And it's such rich in terms of, well, from what parents tell us, one of the biggest barriers that they have is just getting in the door, and that has a lot to do with wait times from our centralized scheduling system. And so again, this primary care physician was stressing the fact that just getting into the door for some of the parents was very difficult. Lack of time, again, this probably comes up a lot. I just don't have enough time. I got a full schedule, and again, our physicians on the call could speak to this. I got 20-minute visits for anything like a flu to a cold to a full visit, physical for a complicated kid. So I don't get enough time to spend with these families. And this whole idea of a team approach, this came up a lot in my interviews with physicians around this whole that really needing additional support. This one physician said, if I just had a social worker on site, that'd be awesome. Because when we make sure that this patient needs transportation, they have patient needs, we just schedule an appointment with a GI. I have a family who is struggling with domestic violence, and I'm trying to make sure that they're plugged in to local resources. Again, addressing the social terms of health, which a lot of these physicians were speaking to in terms of these parents, caregivers having a hard time getting care.
And I think, Albert, we consistently hear from many physicians wanting to do the right thing, but again, lacking those resources and perhaps some of the follow-ups of some of those systems. So those were the results, in short, that we heard from many of our primary care physicians. Now we want to go to the caregivers themselves, and these are going to be the responses from the caregivers who have loved ones with Down syndrome who identify as Black, African American, of African descent, or mixed race. I'm going to present the quantitative results that came from our national survey, and then Albert's going to share with you the real nuance and depth that we got from those interviews that were done in our focus groups. I'm going to walk you through how to read these slides because I'm going to present all of my quantitative data the same way. So we have the question at the top, and you could see the question here is, do you think that most of these groups receive higher quality of medical care, same quality of medical care, or lower quality of medical care in comparison to white patients with Down syndrome? So could those patients with Down syndrome who cannot speak English, how do they compare to their white patients with Down syndrome who can speak English? The entire bar you see represents 100% of the respondents. And broken down on that bar in the red are those who feel that people who in this category cannot speak English got lower quality of medical care in comparison to their white counterparts. Then you can see yellow represents same, green represents higher quality, dark blue represents I don't honestly know, and the light blue just are those participants who left it blank and didn't answer. So a way of visually looking at this is red and yellow represents those who feel that it's a lower quality of care. So the majority of our respondents feel that patients with Down syndrome who cannot speak English get a lower or same quality of care as comparison to their white counterparts. Black or African Americans, you could see greater than 50% of them feel that they're getting lower quality of care. Those who identify as being Hispanic or Latino, you could see it's 25 respondent, which comes to about 35%, and less so for Asian or Asian Americans who feel that they either didn't know or received the same or higher quality of care. The bars are all going to be the same, and on the right, you can see how we label them. In this case, yes is going to be red and no is going to be green. So in the past year, have you personally felt that doctors, nurses, or hospital staff treated your loved one with Down syndrome unfairly or with disrespect because of their racial or ethnic background? You could see of the 68 caregivers who identify as being Black, only about a quarter of them did feel that they were treated unfairly, but it is still a quarter that needs to be addressed. For those that felt they were treated with disrespect because of their child's disability, it was about 25% again. And you could see that a few in the minority, although not zero, feel that they were treated with disrespect because of their inability to perhaps pay for the service or their own religion or religious beliefs. This question was, when your loved one with Down syndrome has been referred for a diagnostic test or appointment, have you ever worried about any of the following? And anything in red or yellow is to an extent, yes, I worry. So you can see about half of parents worry about the time that needs to be taken off of work, whether their loved one with Down syndrome would be treated with respect. About half were concerned about out-of-pocket costs, and about half was worried that whether or not they would be treated with respect. Again, you could see another half felt that no, they didn't worry about that, but there is not a consensus, and we have to be mindful of those who still identify this as a barrier within our system. In general, how important do you feel is for your loved one to be cared for by clinicians who are race and ethnic concordant in cultural religious beliefs, or concordant in gender? You could see the green is very important. So For more than 60% of our participants, they would prefer to have clinicians who are racial or ethnically concordant. About 50% or so want concordance in cultural and religious beliefs, and about 35% or so would prefer to have concordance in gender, matching the gender of their loved one with Down syndrome. We heard a lot about trusted messengers in our previous presentations, and so it is true for parents who have loved ones with Down syndrome. Here is who are your trusted messengers, and more it is green, the more they are trusted messengers. So in these families, they identified doctors and hospitals as being among the top listed trusted messengers. And this is really empowering for those of us in healthcare to realize what a privilege it is to have that trust, but how important it is not to lose that trust. Going in decreasing order, charitable organizations, the internet, and the least likely to be trusted messengers among our respondents were family or friends or religious organizations or leaders, particularly when it came to information about Down syndrome. Albert, I know you heard many of these themes in some of your focus groups.
Definitely, Brian. And I think, again, this is another powerful quote. I think they all are. I think in terms of, parents themselves, look at the other parents, for advice. And this was, I really do rely on two support groups that I'm involved with. Not too many online, because there are so many things out there online that you really don't know if you can't trust it or not. So to me, the support groups really were the key. Again, speaking to the part of this idea of trust, the cost, I think, came up a lot within our focus groups. And I think this, again, powerful quote: the doctors are there, but how you access the healthcare is unequal because how much money you have and how much support. Other people might say Black families do, but to me, it's all about the money. And somebody with money can fly by without a lot of support because of the money they have. They can pay sitters to do this and to that. But if you have no money, the lack of support becomes even more important. And that's from a Black African-American caregiver. Providing Down syndrome resources, information came up a lot around just resources. And our pediatricians help just guide us along the way on providing resources. And so she's been a good resource in addition to the Down syndrome group here. Again, this whole idea of having resources coming from the primary care physician, but also their broader community. And this final one around kind of hesitant or mistrust of online resources came up in the earlier quote. I tend to trust professionals more. So if I go to the internet for some information, it's something that I'll take back either to my group or to a professional, or honestly decipher with experiences they've had with my child to see if it seems right or if the area right, and confirm with the paid professional. Again, this idea of not trusting online resources.
And Albert, I think we've really seen how clinicians and hospitals really rank highly when it comes to the topic of Down syndrome, but how do we build that trusted relationship and break down the barriers that try to strain that relationship? Our third topic is we want to now share with you the same type of data, but this is broken down by the caregivers where Spanish is the primary language spoken at home. And in this particular case, we had 41 families complete, again, available in Spanish, the Spanish-speaking equivalent of this. And you've seen these slides before. So in their viewpoint, do they feel that the following groups receive higher, same, or lower quality of care in comparison to white patients with Down syndrome? And you could see not having accessibility by English, they felt about 30% or 1/3 of the time received a lower quality of care. Just being Hispanic or Latino or Latina, about 30% of the time they felt it was lower quality of care. And then this particular group largely chose not to respond or saying they did not know because they didn't have that lived experience on how they would comment on other racial and ethnic groups like Black, African-American, or Asian Americans. In the last year, do you ever feel that your child with Down syndrome was treated unfairly or with disrespect due to their racial or ethnic background? You could see, unlike the respondents who were caregivers of Black patients with Down syndrome, those who identify as primarily Spanish-speaking were less likely to say these were an issue. You can see the overall reported that these were not an issue, which is reassuring, although it's important to note the small sample size and also notice it is not universal and there is still room for improvement. What do you worry about if you come from a primarily Spanish-speaking household? Again, time off of work was more than 50%. Transportation, about 1/3 of the individuals. About more than 50% of the families, to a certain extent, felt their loved one with Down syndrome who came from a primary Spanish-speaking household, would they be treated with respect? Would they, as the parents, be treated with respect? And close to 50% had some concern about out-of-pocket costs, as we've continued to hear. This is that question about how important it is for the carer or the clinician to be concordant with gender, race, ethnic background, or cultural religious beliefs. You could see here about 1/3 of the time it was important, so still important to many, but we saw it was not as high as it was for those families who identified as being Black, but again, a low number of respondents. Who were your trusted messengers if you came from a primarily Spanish-speaking household? Again, we rank these from highest to lowest. The more green you see here, the more they are a trusted messenger. And there again at the top are clinicians, hospitals, and clinic web pages, again, viewed as trusted sources of reliable information about the topic of Down syndrome. In decreasing order, ending with family or friends. And while many people might find this interesting, we learned from our focus groups that many come from cultural backgrounds where they say Down syndrome is just not understood or it's misunderstood. And I'm tired of having to apologize or explain for my family for having a child with Down syndrome. And so many of them reported that there is a lot of education that they need to do within their own communities that they have to hold. And so this is why when it comes to who am I going to trust for medical care, really kind of referring to the doctors in hospital and clinics tend to be at the highest of their list. And Albert, I know you heard a lot of these themes again in the focus groups.
Yeah, well, again, this is the richness of these conversations. I just remember them vividly, actually, these conversations we were having, again, and this whole idea of the initial diagnosis, this quote speaks really volumes. Yes, it's in relation to the doctors, really, they're the ones who give the news. They give the diagnosis. Yes, they should be more steeped in the topic, because bad handled news affects mothers a lot. Again, I remember these conversations with these caregivers around the fact that some of them were sharing vividly how they got really got the news handled in a very, they just think not in a caring way. And I think it affected them, and they had older kids, and it really just affected them to this day. And so really the initial diagnosis is so important, how you handle that conversation. Caregiving support groups, again, I spoke a little bit to the African-American group as well to this in terms of similarities, but I realized there were no groups in Spanish in my area, and it's a very large area of Latinos. So I started my own group in Spanish in the area, and thanks to that, two foundations that are here, the Down Syndrome Guild and the other ones, began to give classes in Spanish. This whole idea of language is so critical within the Spanish caregiver groups in terms of the importance of having things done in languages that they felt were appropriate for them. Yes.
Albert, I would also say we've heard from some families that the burden oftentimes falls on them to initiate change. So in this particular case, a mother who is primarily Spanish speaking needed to start that initiative, very successful, and she was willing to do that. But we know that it takes a community, as we've learned from ours, to kind of pick up this charge. And oftentimes the groups that need our help cannot initiate the change, and we need to rely on collateral supports and groups to initiate those changes.
Definitely, Brian. Definitely, thanks for speaking to that. And this whole idea of distrust of service providers. When I first my pediatrician, I felt bad because he began to tell me that children with Down syndrome handled a lot with fever, and that you had to be careful, that you had to always be with them. I mean, instead of encouraging me, he made me feel afraid. So that made me feel intimidated. I felt bad. So again, speaking to the idea of just really being able to receive information from care providers who, from physicians who really feel like they have thought through what their responses are going to be, and making sure that they know that these caregivers, are going to receive this information, and it's going to be hard for them.
Albert and I, with our team of stakeholders, now want to present to you, how do we put all of this together? How do we merge the qualitative and quantitative with what we call the take-home points? And what we wanted to do is in the lower right-hand corner, mention whether this is individual change, whether it's structural change, whether it's systemic change, because it definitely is multiple levels of change. And each slide is going to be a particular topic, which you'll see incorporates different data that we've presented to you. So first and foremost, relationships built on trust are crucial for establishing long-lasting medical care. You've heard that throughout multiple different presentations today. Caregivers start by trusting the healthcare system. We're high on the list of trusted messengers. However, it is ours to use as a privilege and ours to break. And when that is broken, it's really hard to unbreak that. So caregivers are also asking that the providers also trust them in return and trust them and not feel like they're being dismissed because of the language or lack of knowledge. And once a trusted clinician is found, parents talk and those referrals pass around and around and those clinicians. So again, parents saying, helping to build that trusted relationship and sharing that information with each other. But it really is an individual change on clinicians' part, on people who are practicing to recognize the position they're in and be able to use it for good and continue to strengthen those bonds within the community.
And, I think caregivers, we're looking for medical providers who demonstrate a willingness to learn about Down syndrome. Again, we heard some of this in the quotes earlier. Caregivers mentioned that they prefer medical providers who treat their loved ones as an individual and not a condition. And this whole idea of the second piece around providers' responsiveness, availability, access were crucial for relationship building. This whole idea of building relationship, and that starts with the providers really being able to see, the child in front of them again, and not the condition, and see the family in front of them as well.
How medical professionals delivered that initial diagnosis could have a long-term impact. And this is called the flashbulb memory from the neurological literature. So whenever we have events in our life that are so salient, we will remember details for a long time. Where were you when 9/11 happened? For those of you who remember JFK being shot, where were you when that happened? People can recall where they were, what they were wearing, what they did next, etc. That is a flashbulb memory, and you remember that. Research has now been done. Receiving a diagnosis of Down syndrome is more of a neurological flashbulb memory than those who experienced 9/11. It is an event that is seared in the minds of families, and if it goes well, then it sets them up for a lifetime of embrace. If it doesn't go well, they will remember those details for a long time. And what we heard from families who came from primarily Spanish-speaking households is they didn't always feel that that initial diagnosis was delivered with compassion. It needs to be delivered honestly, but there is actually online courses and toolkits and research on how to deliver unexpected news in a way that is culturally sensitive, that's accurate, and also sensitive to the needs of the family. So an important step is for clinicians to acknowledge that there is grief and fear at the beginning. This was not necessarily the child that I was anticipating, and that feeling is okay, but together we will work through that feeling. We will find an opportunity to celebrate the richness that comes from neurodiversity. Clinicians can be frank, but need to be hopeful at the same time, and inspiring confidence about the true potential of people with Down syndrome was something that was emphasized multiple times by many families.
And this is a busy slide, so I'm not going to read it verbatim, but I think this whole idea of the medical community needing to recognize that raising a child with Down syndrome can be hard. And I think that the families expressed a lot, and hence why we mentioned this was an individual piece around being able to have, providers and others from an individual standpoint kind of take this onus around making sure that they are conveying to the families and the child that this is going to be a potentially difficult journey. But also as systems, we have to work on this broader system around being able to provide supports for physicians, more being able to just think systematically how the systems can be better informed to help families with not just that initial diagnosis, but just that raising of the child and helping build communities. And so, we again, a couple of these, I think being able to understand that, people can say, hey, just find another provider, because if that's not working, you can find one who gives you great news. But the other day, and let's think about, just in general, trying to find a provider is difficult. So the whole idea of switching providers is hard, and that becomes something you want to be able to have that relationship. And, being able to, primary care teams don't always have this expertise, and Down syndrome specialists are lacking this around the nation. We heard that tremendously from providers around the fact that they, the teams, they just don't have a lot of these specialty clinics across the country. So being able to, and that's a systems problem, right? We need to make sure that we are funding more of these specialty clinics, and so families can have access to them. Because I know Massachusetts is fortunate to have one here, but again, I know California has one as well, but it's very few, around the country. So again, I just read a few of those for the purposes of time.
We also heard from our families, more physicians of color are needed to take care of patients with Down syndrome. Many of the families were looking for providers who were both racial and ethnic concordant. That takes a system change. How do we make sure that there is a pipeline of clinicians who identify as being Black, African American, or Spanish speaking, who are interested in going into genetics, developmental behavioral medicine, into the areas of where our families want to make sure that they have. But we also know it's an individual change as well. We need to, each one of us, be able to make those changes in the system in order to do that. We know, however, that a lack of such providers makes this unattainable in many parts of the United States. And so at the end of this talk, we're going to represent one of our potential solutions of trying to democratize healthcare and be able to extend it to people in many parts of the United States that just don't have the same resources or the number of clinicians who match their racial preferences.
And I think that, everything, a lot comes down to funding, right? I mean, I think we talk about, these, and I think we're not, proposing that these systems changes and even individual changes don't come with a price tag, so I think we understand that this is, but more systematically, we realize that it needs funding, and again, this is something I know that a lot of us on this call probably understand, but, I think just understanding that, PCP, they just can't do this alone. And I think we just need to, and I heard again loud and clear from physicians and clinics that they're just underfunded and they don't have the supports there that they need. So being able to make sure those supports are there. I think having, access to such resources will help caregivers develop a sense of self-efficiency and understanding when and how to get support and how to further engage in the medical community and research opportunities. I think being able to make sure that these supports even extend beyond the clinics and into the community as well. And so we can understand, I mean, this was a sample pilot project we did here, but there's so much need for more research to be done in the African American and the Spanish speaking community. Any of those other ones I want to speak to, Brian? I know there's a lot. We had a busy slide there, but I think
Albert, as you and I always talk about, put money where the priorities are. And
Yep.
if it's going to be a priority, the money needs to follow. And that's at both the kind of local institutional and the big systemic. And it's nice to see progress being made, as you say, but a lot more progress is needed. All of our families mentioned that the system needs to change. Both cultural humility and competency need to be part of a continual education in the healthcare system. And many parents did point out that the medical community's conscious and unconscious biases based on race, ethnicity, and language do affect their loved ones' care. As we heard from the previous speakers, checking our biases and continuing to tap in and review those. There's multiple opportunities for shared dialogue and enhanced learning that's now available. So there is no excuse to say, oh, we just don't know where to turn or we don't know how to be educated. And a big emphasis on continual. It's not one and done, but it's something that we continue to reflect on.
And, and some, caregivers are tired of being reminded by the medical community about their race, and I think this came up, often such references are subtle, but many caregivers want their loved one with Down syndrome to be treated for who they are as a person and not always evaluate through the lens of race and ethnicity. And I know this is somewhat of a challenge for some of us because, we see that Black child in front of us, we see that, Spanish-speaking child in front of us, and we want to look, and we see so many disparities out there, and we understand that health equity is so central in terms of making sure that we're addressing that. But at the same time, I think these parents are saying to us loud and clear, see my loved one for who they are as a person and not look at them as a race and a statistic. And so I think we have to continue to, to look at this from a systems lens. I think this is more in terms of making sure that we're not just focusing so much on race, if that's ethnicity, and losing sight of the fact that there's a child in front of you.
Thanks, Albert. Now we want to share with you quickly on what we're doing with this data. We just don't want to sit on it. We want to be a catalyst for change. And we received additional funding to do diversity awareness building events. These have now been completed. Albert's going to tell you how he did it during a pandemic, but we had 10 events around the country where we engaged families in our data to have those dialogues and also to come up with ways to mitigate some of those barriers that are in place. Albert, I'll let you give a brief overview of what you've been doing.
Just quickly, again, we did these amazing awareness building trips, all about really sharing back the data to the community, because that's really where that's where it belongs. That's where the rich conversation. So we did something called an awareness building trip, where we invited folks onto a call. These were supposed to be in person, but we did them online. And we really did a good job of really engaging community. We gave out an incentive, which was cookies. We made cookies on the call with folks. So we had the caregiver and their loved one on the call. We gave an overview of our work, engaged in some very rich conversations really with them in terms of how they saw what their needs were, really, what they saw as being ways this project could be extended beyond this kind of pilot, and again, just having those rich conversations. And then we shared an example of something, again, as Brian's going to share a little later, about our Down Syndrome to You clinic as a resource for them. Again, so rich conversations, sharing a lot of data, but hearing a lot of rich information from them as well.
And I know Albert planted those seeds so that they continue those conversations within the Down syndrome support group, so the work never ends. Through our same funding agency, we were given funding in order to create what we hope is one part of the solutions. There's a part when you see all of this data and all the systematic change that needs to happen, there's a sense of it's so powerful, but it's so overwhelming. Where do you even begin? And with the inputs of caregivers, we decided to try a small bite in order to be able to democratize healthcare when it comes to people with Down syndrome. And we created something that's called Down Syndrome Clinic to You, and I want to share with you how we did it. It was again created by an internal team of laboratory engineers and who know how to create software. Also, among a great diverse cast and crew of clinicians who have taken care of people with Down syndrome at Massachusetts General Hospital. But we also wanted critical inputs from national advisors. And many of these advisors were also the same advisors on our other work that we had previously presented. But we're very grateful for the experts, the primary care doctors, and the caregivers who have loved ones with Down syndrome to help inform what we've created. It is created right now, so if you're listening and you want to pull out your phone or iPad and bring it up right now, dsc2u.org. It's available completely in English and in Spanish, and I want to walk you through how this works. When a caregiver, no matter where they live in the world, as long as they can access information in English and or in Spanish, they can use any device. It's mobile optimized, can be used on your phone, your iPad, your computer, and you will get an intake form. It's important to know that nothing on this intake form is fill in the blank. It's all click this, or click that. It also has branching logic. So when you enter the information, we will know, do we ask you the 8-year-old questions about Down syndrome or the 55-year-old questions about Down syndrome? The goal of this is we had all of our providers download their brains. So everything that is based on research, based on clinical guidelines, based on our expertise, we have programmed into these answers. So for example, if you have a 9-year-old with Down syndrome who's snoring at night and tired during the day and having academic challenges, we know that those data points likely add up to obstructive sleep apnea. And the recommendation is we need to get a sleep study. No need to make an expensive visit to Boston to see me for me to tell you that we could program into this form that's completed in your home. In short, we will come to you so you don't have to come to us, addressing a couple of the barriers that we heard from our focus groups about transportation being an issue. Transportation is not an issue here as long as you have internet connection. Here you have a series of medical issues that we know in combination can lead to co-occurring conditions that go along with Down syndrome. And I would just point out that on the left are different chapters that families could complete. The more they complete, the more they will get. We basically are trying to simulate the level of care that we're able to provide to those at our Down syndrome specialty clinics to those around the country. When they press submit, no one reviews that information. It goes through our algorithms that we're constantly updating, and this is what a caregiver will get. In their portal, they will get a checklist for them broken down to what they could do right now. And then if they click on the second tab, they will get the same checklist, but written for their primary care doctor. So the next time they have that wellness visit, we're going to turn that primary care physician into a Down syndrome specialist. And in the upper right-hand corner, you could change everything to Spanish. This is an example of what you would see. So for our sample patient, Molly, she needs to get an eye exam, a celiac screen, a sleep study. We have these green Y buttons. And if a parent were to select one of those, we will say exactly what they wrote on the intake form that led to this information. We also spent 2 years curating all of the credible information that's available on the internet, bringing it to parents so they don't have to search for it. So now that we've made them worried about thyroid, if they click on the first link, it'll take them to a free webinar, 20 minutes about thyroid issues and Down syndrome. And the next link will take them to one of the nonprofit Down syndrome organizations who has a great fact sheet about thyroidism. We also, in the next section, have all those co-occurring conditions. How do we make sure we not have diagnostic overshadowing? We see through Down syndrome to be able to treat and identify things like depression, constipation, eczema, all with resources that are available here. And more than just being a medical online clinic, it is there for health and wellness, being able to address things. We offer recommendations to books that are available online or in their local libraries to address some of the issues that might be pertinent. We also want to make sure people with Down syndrome can be as independent as possible. Here are some of the life skills checklists with free access to social stories that are available online. We connect them with resources. So our social worker, how do you get a special needs trust? What is SSI? How do you apply for it? And with a click of a button, everything can be translated into Spanish. I promised you on that second tab would be the same information, but now that can be printed out or emailed to your primary care doctor so you can make sure you democratize healthcare with your established trusted provider. You don't need to see a new trusted provider. You could turn your trusted provider into an expert about Down syndrome, which is one of those take-home points that Albert had shared with us. All of us, caregivers, clinicians, healthcare policy advocates, came together to write up all these results in this article, which was published. We also tested the efficacy of this around the country and show that it is efficacious and it does work. Parents and primary care doctors on a scale of 0 to 10 rated about a 7.8, saying that it's very helpful to the care that they're receiving. It's available right now. You could go to downsyndromeclinictoyou.org. We are a nonprofit. We're operating from Massachusetts General Hospital. We have 3 low-cost ways that families can access it. And again, rather than making any trips or any copays to specialists, they'll be able to access it through these plans. But we're working hard to even democratize the access to healthcare. So while we have real costs to keep this going at Massachusetts General Hospital, we are now working with insurances across the country to make it a win-win. And so we have 2 insurances that are already making this free to members who are in those insurances. And we're also working with local Down syndrome organizations, because these organizations have said, we do all this fundraising, but what's better than the gift of health? And if you go to dscdu.org/organizations, you'll find those Down syndrome organizations that have purchased free access to Down Syndrome Clinic 2 for their members. This is just one small way that we're trying to address some of the disparities through a creative use of online resources. Albert and I cannot say thank you enough to P. Corey, who funded all of our work together. We're also grateful for the NIH through their DS Connect to help recruit people for our studies to give us our rich outcomes. We want to thank you for the opportunity to be with you today. We cannot do it alone, so Albert and I do welcome your feedback. Here's our contact information. Thank you.